People with cognitive mental health issues may have sensitivities or varied abilities or inabilities to cope with common emergency scene conditions, sirens, flashing lights, lots of noise, confusion, numbers of people rushing around, etc. People who have cognitive mental health issues are not always easy to identify, and in many cases do not identify themselves as such. You may not be able to tell if people have cognitive mental health issues until you are interacting and communicating with them. Some cognitive mental health conditions can be misinterpreted. Examples of possible conditions that may be easily misinterpreted will be listed in specific sections that follow. For example, someone might mistake cerebral palsy for drunkenness. Military service members, veterans, and other people may have cognitive mental health conditions due to traumatic brain injuries or post-traumatic stress disorder. General awareness people with cognitive mental health issues may have short attention spans and the need to take more time to comprehend. Difficulty reasoning and solving problems. Difficulty remembering things, planning or organizing. Pressured, halted or broken speech patterns. Augmentative and alternative communication devices. Difficulty with coordination and motor functions. Irrelevant dialogue. Involuntary, non-aggressive or non-directed cursing. Unusual behavior or inappropriate responses, verbal or nonverbal. Example, a building is on fire and the person is talking about the weather. Inappropriate emotions or oversensitivity. People with cognitive mental health issues may not have the ability to read, the ability to speak and make their needs known. People with cognitive mental health issues may show signs of stress and/or confusion in their nonverbal body language, such as confused facial expressions, physical withdrawal from communication, rubbing hands together, rocking, anxiety, overly friendly, indifference, facial flat affect, absence of facial expressions, agitation, personality changes, paranoia or hallucinations, avoidance of eye contact or touch, sudden, repetitive movements or sounds that can be difficult to control, involuntary tics, obsessive repetition of a particular action, word or phrase, bewilderment indicated by the person not able to understand anything that is happening.
General etiquette and tips for dealing with people with mental health, cognitive, intellectual, or developmental impairments include: point to any objects as you speak about them. Use pictures or objects to illustrate your words. Demonstrate what you mean. Showing someone can be more effective than telling. Allow the person to complete his or her sentence or reply. Do not assume the person is unintelligent. Finishing his or her sentence or reply will only frustrate the person and serve to highlight the condition. Avoid interrupting people who might be disoriented or rambling. Be empathetic toward the person. Show that you have heard him or her and care about what he or she has told you. Be reassuring. Rephrase or restate if the person does not understand. Sometimes only one word is causing confusion. If the person is delusional, just let him or her know you are there to help. Remove a person with cognitive mental health conditions from confusion and reduce distractions. Example, lower volume of the radio. Use flashing lights on the vehicle only when necessary. If available, consider noise-canceling devices, such as headphones, for the person with a great sensitivities or confusion. Ask the person if he or she is willing to put them on. Explain what you are doing. Do not shine a flashlight in the person's face or eyes. The use of pen lights for diagnostic information is acceptable.
Mental illness is a term that describes a broad range of mental and emotional conditions. Mental illness also refers to one portion of the broader ADA term mental impairment, and is different from other covered mental impairments such as mental retardation, organic brain damage, and learning disabilities. The term psychiatric disability is used when mental illness significantly interferes with the performance of major life activities, such as learning, working, and communicating, among others. Someone can experience a mental illness over many years. The type, intensity, and duration of symptoms vary from person to person. They come and go and do not always follow a regular pattern, making it difficult to predict when symptoms and functioning will flare up, even if treatment recommendations are followed. The symptoms of mental illness often are effectively controlled through medication and/or psychotherapy, and may even go into remission. For some people, the illness continues to cause periodic episodes that require treatment. Consequently, some people with mental illness will need no support, others may need only occasional support, and still others may require more substantial, ongoing support to maintain their productivity. The most common forms of mental illness are anxiety disorders, mood disorders, and schizophrenia disorders. Anxiety disorders are the most common group of mental illnesses, are characterized by severe fear or anxiety associated with particular objects and situations. Most people with anxiety disorders try to avoid exposure to the situation that causes anxiety. Panic disorder is the sudden onset of paralyzing terror or feeling of impending doom with symptoms that closely resemble a heart attack. Phobias are excessive fears of particular objects, simple phobias, situations that expose a person to the possible judgment of others, social phobias, or situations where escape might be difficult, agoraphobia. Obsessive-compulsive disorder is having persistent distressing thoughts, referred to as obsessions, that a person attempts to alleviate by performing repetitive, intentional or compulsive acts, such as hand-washing. Post-traumatic stress disorder, PTSD, is a psychological syndrome characterized by specific symptoms that result from exposure to terrifying, life-threatening trauma, such as an act of violence, war, or a natural disaster. The person has been exposed to a traumatic event in which both of the following have been present. The person experienced, witnessed, or was confronted with an event or events that involved actual or threatened death or serious injury, or a threat to the physical integrity of self or others. The person's response involved intense fear, helplessness, or horror. The traumatic event is persistently re-experienced in one or more of the following 5 ways. Recurrent and intrusive distressing recollections of the event, including images, thoughts, or perceptions. Recurrent distressing dreams of the event. Acting or feeling as if the traumatic event were recurring includes a sense of reliving the experience, illusions, hallucinations, and dissociative flashback episodes, including those that occur upon awakening or when intoxicated. Intense psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. Physiological reactivity on exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. Avoidance behavior represents an effort to withdraw from certain situations that bring about body-level distress of trauma-related symptoms. Here are some examples. Efforts to avoid thoughts, feelings, or conversations associated with the trauma. Efforts to avoid activities, places, or people that arouse recollections of the trauma. Inability to recall an important aspect of the trauma. Markedly diminished interest or participation in significant activities. Feeling of detachment or estrangement from others. Restricted range of affect, for example, unable to have loving feelings. Sense of a foreshortened future, for example, does not expect to have a career, marriage, children, or a normal lifespan. Increased arousal may be demonstrated by the person as well. Here are some examples. Difficulty falling or staying asleep. Irritability or outbursts of anger. Difficulty concentrating. Hypervigilance. Exaggerated startle response.
Agitation. Mood disorders are also known as affective disorders or depressive disorders. These illnesses share disturbances or changes in mood, usually involving either depression or mania. With appropriate treatment, more than 80% of people with depressive disorders improve substantially. Major depression is an extreme or prolonged episode of sadness in which a person loses interest or pleasure in previously enjoyed activities. Bipolar disorder, also referred to as manic depressive illness, is alternating episodes of mania or highs and depression or lows occurring over weeks at a time, not suddenly. Seasonal affective disorder, SAD, is a form of major depression that occurs in the fall or winter and may be related to shortened periods of daylight. Schizophrenia disorders. Research has not yet determined whether schizophrenia is a single disorder or a group of related illnesses. The illness is highly complex, and few generalizations hold true for all people diagnosed with schizophrenia disorders. However, most people initially develop the symptoms between the ages of 15 and 25. Typically, the illness is characterized by thoughts that seem fragmented and difficulty processing information. Symptoms of schizophrenia disorders are categorized as either negative or positive. Negative symptoms include social isolation or withdrawal, loss of motivation, and a flat or inappropriate affect, mood or disposition. Positive symptoms include hallucinations, delusions, and thought disorders.
Essential tips/etiquette. Media fuels misconceptions about mental illness. Fear of people who are mentally ill often stems from inability to communicate and lack of knowledge about mental illness. In our society, there is a powerful negative stigma attached to mental illness, especially the more severe forms, such as schizophrenia. Most people who are mentally ill are no more likely to be dangerous than the general population, but because of their bizarre and unpredictable behavior, they often frighten people. Mental illness can affect behavior and communication skills. Respect personal space, and do not touch the person, or their belongings. If touching becomes necessary, explain the process step by step. Some people with paranoia may be frightened, so be aware that they may need more personal space than you may usually give. A touch on the shoulder can be comforting to some, but anxiety-provoking to others. Just ask, for example, "May I touch your arm?" or "May I look in your eyes?" Do not assume that they are not smart and will believe anything you tell them. Do not lie to them, as it will usually break any rapport you might want to establish. Consider differential diagnosis. Do not get tunnel vision. Do not give multiple commands, ask or state one thing at a time. If they are experiencing events such as hallucinations, be aware that the hallucinations or the delusions they experience are their reality. You will not be able to talk them out of their reality. They experience the hallucinations or delusional thoughts as real and are motivated by them. Find out what reality-based needs you can meet. Look for common ground. Focus on observable facts. Emphasize, "We are all here for your safety." Remove yourself from the situation if you think you are getting agitated with the person, hand off to a partner. Know what pushes your buttons.
Here are some suggested communication techniques. Relax, stay calm, and present an open stance. Start a conversation with the expectation that things will go smoothly. Listen to the person and try to understand what he or she is communicating. Speak in a normal, calm tone. Listen and make eye contact, unless this is threatening. Use I statements, not you statements, such as "I understand you aren't feeling well." Acknowledge what the other person says and how he or she feels, even if you do not agree. Paraphrase, "If I understand you correctly, you and I, or is that what you're saying?" Engage the person in the process by asking for opinions and suggestions. Watch out for contradictory messages between verbal and nonverbal messages. Stick to present issues. If needed, set limits with the person as you would others. For example, "We have only 5 minutes before we must go," or, "If you scream, I will not be able to talk to you." Avoid general and loaded words such as always or never. Use specific words instead. Ask yes or no questions and repeat them if necessary. Providing assistance, and removing barriers. Turn off emergency lights and sirens if possible. Minimize environmental noise, such as flashing lights, sirens, and crowd confusion. Reassure the person often and do not assume the person does not understand because he or she does not use words. To maintain continuity of care with the person with whom you have developed a rapport, if at all possible, avoid unnecessarily transferring care from one person to another. Multiple interactions with new people may cause the person to become angry or violent. Refer the patient to someone else only if it is an appropriate referral. Keep a current list of community resources, such as shelters, food programs, and mental health services that you can suggest. Call for help from mental health professionals or colleagues if you need help de-escalating the person. Call for help from police or security if you feel physically threatened.
Cognitive disability refers to disturbances in brain functions, such as memory loss, problems with orientation, distractibility, perception problems, and difficulty thinking logically. These disabilities may have their origins in physiological or biological processes within the person, such as a genetic disorder or a traumatic brain injury. Other cognitive disabilities may be based in the chemistry or structure of the person's brain. Learning disabilities. Lifelong disorders that interfere with a person's ability to receive, express, or process information. Developmental disabilities. Lifelong disabilities resulting from physical or intellectual impairments, or a combination of both. These disabilities present themselves before the age of 22 and affect daily functioning in 3 or more of the following areas. Ability to support oneself economically. Ability to live independently. Mobility. Learning. Receptive and expressive language. Self-care. Self-direction. The disability can be severe, moderate, or mild, depending on a person's support needs. People with intellectual disabilities, cerebral palsy, autism spectrum disorders, or genetic disorders such as Down syndrome are said to have developmental disabilities. Dementia. This is not a specific disease. Instead, it describes a group of symptoms affecting intellectual and social abilities severely enough to interfere with daily functioning. It is caused by conditions or changes in the brain. Different types of dementia exist depending on the cause. Alzheimer's disease is the most common type. Alzheimer's disease is a type of progressive dementia caused by the destruction of brain cells. Although the exact cause is not known, 2 types of brain cell damage are common in people who have Alzheimer's disease. Alzheimer's disease usually progresses slowly, over 7 to 10 years, causing a gradual decline in cognitive abilities. Eventually, the affected part of the brain is not able to work properly because of limited functions, including those involving memory, movement, language, judgment, behavior, and abstract thinking. Alzheimer's disease is the most common cause of dementia in people age 65 and older. Symptoms usually appear after age 60, although early onset forms of the disease can occur, usually as the result of a defective gene. Traumatic brain injury, TBI. Traumatic brain injury can result from blunt or penetrating causes. Mild traumatic brain injury may cause temporary dysfunction of brain cells. More serious traumatic brain injury can result in bruising, torn tissues, bleeding and other physical damage to the brain that can result in long-term complications or death.
Cognitive disabilities. Some people with a cognitive disability may have above-average intelligence, but may have difficulty receiving, expressing, or processing information. Other people with more profound cognitive disabilities often need assistance with simple tasks. Ask the person if he or she prefers verbal or written communication, or some combination. For example, if providing verbal instructions, it may be helpful to give written material. Be patient, allow the person time to think, and answer any questions independently. Do not take lack of response personally, the person may be processing what was just asked, or discussed. Be aware that direct eye contact can be intimidating. Learning disabilities, LD. Learning disabilities are lifelong disorders that interfere with a person's ability to receive, express or process information. Most people with LD have average or above average IQs. Allow extra time for reading, writing, response, etc. Ask best way to relay information. Provide written instructions and information. Provide technologies that support learning strengths. Developmental disabilities. Use clear sentences and concrete concepts. Treat as adult and allow to make decisions. Allow adequate time to complete tasks and make decisions. Provide pictograms. Allow time to adjust to change in environment or routine. Dementia and memory loss. Ask yes or no questions, repeat them if necessary. Maintain eye contact. Disabilities impacting speech. Give the person your full attention. A person who has had a stroke, is deaf, uses a voice prosthesis or has a stammer or other type of speech disability may be difficult to understand. Do not pretend to understand what he or she are saying if you really do not. Ask him or her to repeat it. If you are not sure whether you have understood, you can repeat for verification. If you still do not understand what someone is saying, consider asking the person to write it down. Nodding heads does not mean the person understands. It is okay to ask the person to repeat what you said or if he or she understood.
Establishing a patient relationship. Consider that uniforms may be intimidating. Speak directly to the person, not to his or her caregiver. Ask the person, do you want your support worker to stay with us? Ask simple introductory questions, such as, name or the reason for the EMS visit. Explain the process and purpose of the EMS interaction in simple terms. Gain the person's attention and eye contact, if possible, by using his or her name, or by touching his or her arm before speaking. Determine how the person communicates. If the person uses a communication technique or device, involve a caregiver who is familiar with it. Show warmth in a positive regard. Encourage the use of comforters, for example, a favorite item the person likes to carry, or a preference for standing and pacing, rather than sitting. For people with autism and related disorders, respect the preference to avoid eye contact. Use positive comments and positive reinforcement. Focus on the person's abilities rather than disabilities. Choosing appropriate language. Use concrete language. Use concrete as opposed to abstract language, for example, show me, tell me, do this with gesture, come with me, I'm going to. Say, put your coat on, instead of get ready. Say, are you upset? Are you sad? Are you happy, instead of what are you feeling? To make the concept of time more concrete, use examples from daily and familiar routines, example breakfast time, lunch time, bedtime. Listening. Listen to what the person says. Let the person know when you do and do not understand. Be sensitive to tone of voice and nonverbal cues. Differences in muscle tone for some people may complicate reading their facial expressions or body language. Check and validate your perceptions. Be aware that the interaction will likely take more time than usual. Explaining clearly. Explain what will happen before you begin. Tell and show what you are going to do and why. Rephrase and repeat questions, if necessary, or write them out, if the person is able to read. Checking for understanding is essential. For people who can speak in sentences, ask questions such as, can you tell me what I just said? Can you tell me what I am going to do and why? Communicating without words. Use visual aids. Act or demonstrate. People with limited language ability and understanding rely on familiar routines and environmental cues to understand or anticipate what will happen next. Use simple diagrams and gestures. Use pictures when communicating. Find signs in the person's communication book or point to familiar objects. Some people may express themselves only in writing. When possible and safe, allow the person to handle and explore equipment. Point to body parts and act out actions or procedures, for example, checking the person's ears.
This is Travis King, whose parents spearheaded the Travis Alert Act to help educate responders. Autism spectrum disorder, ASD, is a range of complex neurodevelopment disorders, characterized by social impairments, communication difficulties, and restricted, repetitive, and stereotyped patterns of behavior. Autistic disorder, sometimes called autism or classical ASD, is the most severe form of ASD, while other conditions along the spectrum include a milder form known as Asperger's syndrome, the rare condition called Rett syndrome, and childhood disintegrative disorder and pervasive developmental disorder not otherwise specified, usually referred to as PDD-NOS. Although ASD varies significantly in character and severity, it occurs in all ethnic and socioeconomic groups, and affects every age group. Some characteristic difficulties in behavior, social interaction, communication is common among people on the spectrum. Others are typical of the disability but not necessarily exhibited by all people on the autism spectrum. Behavior displayed by the person is due to the difficulties he or she has responding to the environment. Their behavior is generally an attempt by them to communicate their feelings or to cope with a situation. Behavior problems may occur as the result of their heightened sensitivity to a sound or something he or she may have seen or felt. For people on the spectrum, rigidly sticking to routines and spending their time in repetitive behaviors are ways for them to reduce uncertainty and to maintain the predictability of their environment. Other behaviors may include unusually intense or focused interests, stereotyped and repetitive body movements such as hand flapping and spinning, repetitive use of objects such as repeatedly switching lights on and off or lining up toys, insistence on sticking to routines such as traveling the same route home each day and doing things in the exact same order every time, unusual sensory interests such as sniffing objects or staring intently at moving objects, sensory sensitivities including avoidance of everyday sounds and textures such as hair dryers, vacuum cleaners, and sand. Social interaction is poor with people who have autism as they have difficulty establishing and maintaining relationships. They do not respond to many of the nonverbal forms of communication that many of us take for granted, such as facial expressions, physical gestures, and eye contact. They are often unable to understand and express their needs, just as they are unable to interpret and understand the needs of others. This impairs their ability to share interests and activities with other people. For this reason, they may appear distant and aloof. Because they are often delayed in their speech and struggle to make sense of other nonverbal forms of communication, they may withdraw into repetitive play and behavior, and avoid interaction. Their difficulties with social interaction may manifest in the following ways: limited use and understanding of nonverbal communication such as eye gaze, facial expression and gesture, difficulties with social and emotional responsiveness, difficulties forming and sustaining friendships, lack of seeking to share enjoyment, interests, and activities with other people. Communication difficulties, in one form or another, are common for people who have autism. Some people with autism speak fluently, others are speech impaired to varying degrees, and others still are unable to speak at all. Those who can speak will often use language in a very limited or unusual way. Their line of conversation may involve repeating your phrases or words back to you or asking the same questions over and over. People with autism will usually talk about only topics that are of interest to them, which makes the give and take in communication difficult. They have difficulty interpreting nonverbal forms of communication such as facial expressions, hand gestures, and other body language. Impaired communication is characterized by delayed language development, difficulties initiating and sustaining conversations, stereotyped and repetitive use of language such as repeating phrases from television.
When interacting with EMS and police, people with autism might not respond to their name or verbal commands such as stop. It may appear that the person is ignoring you when the person is overwhelmed or fixated on an interest. The autistic person may repeat exactly what you say back to you without any appearance of understanding the question due to underdeveloped communication skills. They may avoid eye contact or reacting with discomfort when eye contact is attempted. They may ignore warnings of entering dangerous situations due to an impaired sense of danger, for example, wandering to bodies of water, traffic, or other dangers and not stopping when asked. The autistic person may also be overwhelmed by EMS or police presence, exhibiting fear or distress to raised voices or uniforms. Reach for police equipment due to a decreased understanding of boundaries, social rules, and danger. Engage in repetitive behavior, repeating the same noise or phrase repeatedly, rocking, biting their hands, scratching themselves, or rocking. Have impaired sensory perception, which may present as being under or overdressed for the weather, being obviously injured but not showing any pain or asking for help. Not speak or make eye contact. Become distracted by smells. Become excited, frightened, or distracted by noise and lights around them. Try to minimize these environmental conditions. Experience a meltdown. When a person with autism becomes overstimulated or anxious, he or she may lose control and melt down, exhibited by yelling, screaming, throwing, or breaking objects, hitting themselves or those around them. Meltdowns and tantrums appear similar, but tantrums are manipulative in nature and end when the demand is met. Meltdowns are a loss of control and generally must run their course. The person experiencing the meltdown may attempt to remove themselves from the meltdown trigger by walking or running away. If he or she are removing themselves to a safe location, allow them to do so and follow at a safe distance. Do not physically intervene unless there is a safety risk. Instead, try to reduce stimuli, reduce flashing lights, sirens, crowds, or loud voices. Follow the guidance of the guardian. He or she likely have extensive experience in managing the person's behavior. Unless absolutely necessary, do not touch a person with autism without his or her permission. People with autism are often sensitive to touch, and touch can be painful. If a person with autism begins to wave their arms around, do not try to hold the person's arms. Usually within a short period of time this will stop. It is a sign that the person is frustrated, frightened, and/or experiencing something very different. Look for signs of stress or confusion, and understand that rocking, repetitive motion, and repeating words or phrases may be comforting to a person with autism. Repeat reassurances, but do not assume the person doesn't understand because he or she does not use words. Remove additional stimulus if possible. For example, in a crowded room, request that the other people leave, remove barking dogs, turn off alarms, flashing lights, sirens, etc. Move slowly and explain calmly what you are doing. If the person does not appear to understand, request a social worker come to assist, if possible. Be aware that people with autism may agree to questions due to lack of understanding, desire to please you, or desire to escape your questions or presence. They may say they did something in the hopes you will stop asking. This will lead people with autism to confess to crimes they did not commit or describe inaccurate medical symptoms and history. Do not question the person without first speaking with their caregiver. Be careful to ask questions that do not suggest the answer. If the person is alone, attempt to locate the caregiver by looking for medical identification, asking to see the person's wallet, keys, and communication devices, or to look in their backpacks or other places a caregiver might write their contact information. When interacting with people with autism, be clear and direct, avoid figurative language. Approach the person in a quiet, non-threatening manner, giving them plenty of space and time to respond. Do not threaten the person with punishment. When interacting with caregivers and parents, allow them to explain the situation before reacting, e.g. why the parent is restraining the child. When talking to a person with autism, use a calm voice, use simple and short sentences. Give at least 2 minutes for the person to process what was said to them and respond to a question or command. Delayed processing means that the person may need additional time to respond. If he or she do not respond, repeat the question or command slowly and calmly. Avoid using figurative language. If the person has an iPad or other assistive technology device with them, do not remove it. The person may use this to communicate with you. If the person's interests are obvious, such as the person is wearing a lot of Mario clothes or has a toy with them, attempt to engage the person in talking about it or bring up a related YouTube video on a phone to distract them. Sensory overload is the major barrier to communication and compliance when dealing with the autistic person. Again, if the caregiver is present, ask them how to communicate with the person.
Remind search and rescue personnel to consider looking in and around nearby bodies of water when searching for a missing child with ASD, under the age of 14. Step back and consider what behavior is necessitating the response of EMS or law enforcement. For example, is the person repeatedly trying to get into a house he or she does not live in, or that he or she lived in before? If you can discover the function of the behavior, you can use this to help calm the person. A possible scenario would be the person is stealing food from the store near where he or she may live, because they may be out of their favorite food, and have simply gone to where he or she knows it is, without understanding the consequences. First response agencies could help identify resources the caregiver can use to stabilize the person. It is recommended that regional police and EMS agencies develop and maintain a list of crisis and support services for people with autism and their families. These should include prevention and safety resources for the family. It is recommended that first responders develop a local database of at-risk people. Information for this database could be provided by caregivers in order to give law enforcement and EMS responders information helpful in dealing with autistic care receiver.
A dog guide, as defined in Revised Code of Washington 49.60, is a dog that is trained for the purpose of guiding blind people or a dog that is trained for the purpose of assisting hearing-impaired people. A service animal, as defined in Revised Code of Washington 49.60, is an animal that is trained for the purpose of assisting or accommodating a disabled person's sensory, mental, or physical disability. Service animals. Only dogs are recognized as service animals under Titles 2 and 3 of the Americans with Disabilities Act. Generally, Title 2 and Title 3 entities must permit service animals to accompany people with disabilities in all areas where members of the public are allowed to go. A service animal is a dog that is individually trained to do work or perform tasks for a person with a disability. Dogs whose sole function is to provide comfort or emotional support do not qualify as service animals under the Americans with Disabilities Act. Service animals are working animals, not pets. Examples of such work or tasks include guiding people who are blind, alerting people who are deaf, pulling a wheelchair, alerting and protecting a person who is having a seizure, reminding a person with mental illness to take prescribed medications, calming a person with post-traumatic stress disorder, PTSD, during an anxiety attack. The practice of non-disabled people passing off pet dogs as different types of service dogs has eroded the rights of real assistance dog handlers, especially those with invisible disabilities. Do not make assumptions. If you see a person who can walk and talk, and he or she is sighted, and he or she is hearing, the dog may be alerting to diabetes or seizures. Those tasks may be done by a breed that doesn't fit the popular image of a service dog, such as a retriever or a German shepherd. As the list of jobs for service dogs grows, so does the diversity of service dog breeds that are helping people with disabilities. Miniature horses. In addition to the provisions about service dogs, the Department's revised Americans with Disabilities Act regulations have a separate provision about miniature horses that have been individually trained to do work or perform tasks for people with disabilities. Generally, these miniature horses range in height from 24 inches to 34 inches measured to the shoulders, and weigh between 70 and 100 pounds. Entities covered by the Americans with Disabilities Act must modify their policies to permit miniature horses, where reasonable. The regulations set out 4 assessment factors to assist entities in determining whether miniature horses can be accommodated in their facility. The assessment factors are: whether the miniature horse is housebroken, whether the miniature horse is under the owner's control, whether the facility can accommodate the miniature horse's type, size, and weight, whether the miniature horse's presence will not compromise legitimate safety requirements necessary for safe operation of the facility. Types of service animals. Guide dogs. Guide dogs have been helping visually impaired people for centuries. While people often expect guide dogs and other assistance dogs to wear vests, the Americans with Disabilities Act does not require a vest, although the dogs will often be wearing a special harness with a handle on it. Assistance dogs that lead visually impaired and blind people around obstacles are one of the most commonly known types of service dogs. Labrador Retrievers, Golden Retrievers, and Lab Golden hybrids are often dog breeds chosen as guide dogs, although other breeds, such as poodles, can also be well suited to be this type of service dog. Hearing dogs. For people with hearing impairments, these types of service dogs assist by alerting their human to noises such as alarms, doorbells, or crying babies. When the dog hears the sound, it will touch the human and lead toward the noise. Labradors and Golden Retrievers are dog breeds that are often selected as hearing dogs, but other breeds, including Cocker Spaniels and miniature poodles, have been successfully trained to alert as a hearing dog. Terrier mixes, poodles, cockers, Lhasa Apsos, Shih Tzus and even Chihuahuas are being selected for personality and temperament, and are trained to alert as a hearing dog. Mobility assistance dogs. These types of service dogs can perform a wide range of tasks for people with a wide range of mobility issues. According to Service Dogs of America, mobility assistance dogs can bring objects to people, press buttons on automatic doors, serve as a brace for people who are ambulatory, or even help pull a wheelchair up a ramp. These dogs help people increase their independence and confidence. People with spinal cord injuries, brain injuries, muscular dystrophy, and arthritis are among those who benefit from being partnered with a mobility assistance dog. Different breeds are selected depending on the handler's size, but the dogs must be large enough to support their human partner. Diabetic alert dogs. Also known as DADs, these types of service dogs can provide independence and security by alerting to chemical changes in their handler's blood sugar. The scent changes associated with hyperglycemic or hypoglycemic events in diabetics are imperceptible to humans, but dogs can pick up on them and alert their people to blood sugar highs and lows before the levels become dangerous. When a diabetic alert dog alerts, its human then knows to test his or her blood, then inject insulin or ingest a dose of glucose before the blood level gets dangerous. Many of these dogs are trained to go alert others in the household or set off an alarm system if their human needs medical help. Seizure alert dogs. Seizure alert dogs are a controversial type of service dog that react with a specific type of behavior right before his or her human has a seizure. The ability to alert to seizures seems to be a natural ability for a small number of dogs, although some neurology experts say no reliable evidence suggests dogs can reliably predict seizures. Seizure response dogs. Not to be confused with seizure alert dogs, seizure response dogs are trained to provide help to a person experiencing an epileptic seizure, not to predict the seizure. These dogs can be trained to bark for help or to press an alarm system during a person's seizure. They can also get a person out of an unsafe place during a seizure and help the handler to come around when the seizure ends. These dogs may also bring medicine or a phone to a person who is coming out of a seizure. Psychiatric service dogs. This versatile category of service dog assists people who are suffering from issues such as depression, anxiety, and most often post-traumatic stress disorder. Human handlers in this category can feel hypervigilant about their safety, and service dogs can make them feel safer by doing things such as entering the home before the human, and turning on the lights with a foot pedal. These dogs can also help PTSD sufferers who feel overwhelmed in public places by creating a physical barrier between the handler and others, giving the handler more personal space. Many PTSD sufferers find that having a service dog to care for forces the human to also take care of themselves, by getting out into the world and getting exercise with the dog. Autism support dogs. For children on the autism spectrum, these types of service dogs help provide a sense of predictability as the children navigate social settings, including school. The dogs can be a big help for children who have trouble connecting with classmates, as the canine acts as an icebreaker in social situations. In addition to improving the child's quality of life by reducing isolation and comforting the child in stressful times, these dogs are also trained to keep children from running away and can often track children if they do run off. Fetal alcohol spectrum disorder, FASD, service dogs. An emerging category of service dog, these dogs support children who were exposed to alcohol prenatally, and have been diagnosed with fetal alcohol spectrum disorders. These children may have physical and mental difficulties, as well as behavioral problems and learning disabilities. FASD dogs are trained similarly to autism service dogs and can be trained to interrupt a repetitive behavior. Allergy detection dogs. With the rise in food allergies has come another type of medical service dog. Allergy detection dogs are trained to sniff out and alert to the odor of things such as peanuts or gluten. Often partnered with children, allergy detection dogs can be trained to alert to allergy-inducing smells at school, providing the kids with a greater sense of independence. Under the Americans with Disabilities Act, service animals must be harnessed, leashed, or tethered, unless these devices interfere with the service animal's work or the person's disability prevents using these devices. In that case, the person must maintain control of the animal through voice, signal, or other effective controls. When it is not obvious what service an animal provides, staff members may ask two questions. Is the dog a service animal required because of a disability? What work or task has the dog been trained to perform? Staff members may not ask about the person's disability, require medical documentation, require a special identification card or training documentation for the dog, or ask that the dog demonstrate its ability to perform the work or task. Allergies and fear of dogs are not valid reasons for denying access or refusing service to people using service animals. A person with a disability may not be asked to remove his service animal from the premises unless the dog is out of control and the handler does not take effective action to control it. The dog is not housebroken. When there is a legitimate reason to ask that a service animal be removed, staff members must offer the person with the disability the opportunity to obtain services without the animal's presence. Staff members are not required to provide care or food for a service animal. If you have doubts, wait until you arrive at your destination and address the issue with the supervisor in charge. Other kinds of working dogs, including therapy dogs and emotional support dogs, are not classified as service animals as they're not trained to perform a specific task to help their handlers. In most jurisdictions, these kinds of dogs are not afforded the same privileges as service dogs. Many service animals such as guide dogs are very expensive to train, and trying to treat them like a pet is likely to break the training regime. Remember, that dog is that user's eyes, ears, or otherwise. Recognize the service animal as medical equipment. In the event you are asked to take the dog while assisting the person, hold the leash and not the harness. Service animals are generally loved by their handlers, and the two share a unique bond. Keep in mind, though, that these animals are not pets. Service animals provide essential assistance to their handlers and are medically necessary. Avoid distracting the service animal. Keep in mind that service animals have a specific job to do, and that their handlers rely on them for safety and protection in public. Feeding, playing with, talking to, or otherwise engaging the animal can be distracting for it. You should avoid distracting the animal in any way unless you have permission from the handler. Keep in mind that some handlers have disabilities that cause anxiety or social difficulties, so they may not be able to say no to you. A service animal may wear a patch such as, "Ask before petting," or, "Do not distract." If you do not see a patch, play it safe and do not interact. If the handler is open to letting you interact with the animal, he or she will tell you. Some animals, such as emotional support animals, can sometimes interact with you, if it is okay with the handler. Other animals, such as seizure alert dogs, need to stay focused at all times in order to keep the handler safe. Do not ask the animal to do tricks or to perform tasks. Do not call attention to the animal or take pictures without clear permission from the handler. Avoid getting in the way of the animal. Just as you would not forcibly move someone's arm or block their leg, give the animal space to do its job. Making eye contact with the animal could distract it from its work, which could be dangerous to the handler. Teach children not to interact with a service animal, because it's busy working. If it appears that the handler needs help with the animal, you may politely offer assistance. For example, if the handler cannot access an area where the dog may relieve itself, you could say something such as, "Would you like me to walk your dog over to the grass?"
Suggested communications techniques when dealing with people with service animals. Talk to the handler normally and leave the animal alone. There is no need to ask about their disability or their service animal. This person has a service animal because of a disability, so avoid saying insensitive things such as, "That dog is really nice, I wish I had a service dog." If a patron, coworker, or employee brings a service animal into your establishment, you might want to ask questions. Keep in mind that medical privacy comes into play when discussing a service animal. While you are not banned entirely from asking questions, you are allowed to ask only two under federal law. Those questions are: is the dog a service animal required because of a disability? And what work or task has the dog been trained to perform? It is impolite, and in some cases illegal, to ask a person with a service animal what his or her disability is. He or she has the right to medical privacy just like any other person. Know the federal law protecting service animals. Under the Americans with Disabilities Act, only dogs and miniature horses are considered service animals. The animals are allowed anywhere that the public is allowed, and no proof must be carried to verify the animal's training or the handler's disability. The Americans with Disabilities Act requires that public transportation systems allow service animals to travel with their handlers. This includes ambulances. The animal will often lie at the handler's feet, or remain in the handler's lap.
Summary, general overall tips and etiquette. put the person first and his or her disability second. Use common sense. Do not make assumptions about needs, abilities, or limitations. Disability comes with varying levels of limitations. Do not get tunnel vision. Create an environment that permits people with non-visible disabilities to disclose if necessary. If you want to help someone, ask first. If the person needs help, he or she likely will instruct you on how best to give assistance. Treat adults as adults. Apply basic courtesies to all people. Do not be condescending, or treat people with any type of disability as if he or she were a child, unless he or she is a child. Be sensitive about physical contact. Always speak to people with a disability directly when they present themselves to you. Try to include the person in conversations with other people. Do not talk about a person in front of that person. Do not assume that people do not understand just because they do not use words to communicate. It is okay to use phrases such as walk with me, see you later, or did you hear about that? People with disabilities will do so, too. Do not ask personal questions you would not ask of a person who is not disabled. Ask for and look for an identification bracelet with special health information. Emergency contact information to reach the person's family. Essential equipment and supplies, for example, wheelchair, walker, oxygen, batteries, communication devices. Specific health instructions, for example, allergies. Specific communication information, for example, is the person using sign language. Signs of stress and/or confusion, for example, the person might say he or she is stressed, look confused, withdraw, start rubbing the hands together. Conditions that people might misinterpret, for example, someone might mistake cerebral palsy for drunkenness.
Summary, general overall communication. People with speech disabilities, people with cognitive difficulties, people with significant hearing loss or anyone with limited English proficiency may not be able to use audible and/or intelligible speech to communicate. People who have difficulty speaking may also have difficulty understanding what other people are saying. People with communication limitations are a vulnerable population in any emergency or disaster. If the person does not use words to speak, look for gestures or other behaviors that communicate what the person is wanting to express. Begin by identifying basic communication methods. Pay attention to pointing, gestures, nods, sounds, eye gaze and eye blinks. Example questions to establish good communication could include: show me how you say yes. Show me how you say no. Show me how you point to something or someone you want. After communication methods have been identified, ask a few basic questions. Is someone here who can help me communicate with you? Do you have a communication board, communication book, or a speech-generating device? Did you bring it with you? If the person indicates yes, ask where it is and help retrieve it. If the person indicates no, go to the Picture Cues tab. Present paper and writing utensil or a communication board if possible. Use pointing and gestures to show what you want the person to do. Watch for signs that the person is deaf or hard of hearing. Ask questions that can easily be answered with a yes or no response. Ask questions one at a time and slowly. Give the person extra time to respond. Take time to listen carefully. Maintain eye contact if possible and appropriate. Maintain appropriate facial expressions. If you look angry or annoyed, the person may be less cooperative. Do not pretend to understand when you do not. Repeat what you do understand, and ask for the part you didn't understand to be repeated. Part of the legislation called for EMS providers to have a checklist of key considerations to think about when interacting with people with access and functional needs. These are general considerations, and specific considerations are listed in the following slides relative to the topic. General, immediate actions items. Safety of EMS personnel and bystanders. Respect personal space. Use calm tone. Include the patient in planning and decision making. Assess and treat immediate life threats. What physical barriers need to be removed? Consider the need for outside resources.
Key considerations for mobility and physical impairments. Transport assistive devices, used by patient, should accompany the patient when possible. Arrange for alternative transport for the device, or find a method of securing the device, if it is not possible to transport the device. Consider using the same method of transport for the patient that was used in the past. Request other resources if special considerations in handling and transport are needed. Key considerations when dealing with a person with visual impairment. Determine the degree of vision deficit. Speak directly to the patient. Do not shout or use non-specific words and phrases such as "watch out." Determine if assist devices or service animals are used. Key considerations when dealing with a person with a hearing impairment. Determine the degree of hearing deficit. Determine which communication techniques are best to use, such as lip reading, signing, or the use of written language. Look for someone to help you to communicate. Use a family member or other resource immediately available who is able to assist, if appropriate. Key considerations when dealing with a person with mental health or cognitive issues. Check their blood sugar. Consider the differential diagnosis. Consider medical or traumatic conditions. Avoid sensory overload or triggering actions when interacting with the patient. Use a calm voice, and avoid escalation. Use an open posture. Avoid prolonged eye contact. Consider other resources for safety.
Key considerations when dealing with a person with autism. Avoid sensory overload and triggering actions such as sounds or bright lights when interacting with the patient. Discuss requirements for successful interaction with the person's caregiver. Use a calm tone of voice. Also remember to acknowledge and validate emotions. Key considerations when dealing with service animals. Assure the service animal is transported with the patient. Request additional assistance, should the animal not be able to accompany the patient. The Washington State Department of Health includes, on its website, a list of public and private nonprofit disability-related agencies and organizations, and the contact information for each agency and organization.
Thank you for participating in this program. The information presented here is designed to help us perform our services compassionately to these members of our community. If you have any questions on local policies or procedures, contact the Kitsap County EMS office.